Mobility is bad around implants. That means something is happening. Sometimes it's something happening that's bad but fixable. Sometimes it's bad and not so fixable. So test it. The one that is not too bad is if the abutment is not down all the way on the implant. So you get mobility of the implant. What was holding it in was this screw. It didn't have good attachment. The patient functions for a period of time. The crown and the abutment starts to move. If you take an x-ray, normally you'll see this little gap that's between the abutment and the implant itself. Also, if you have irritation at that gap, you can see what looks like a little fistula that forms around the tooth. This is basically bacterial accumulation at this gap. Sometimes it's related to the mobility, sometimes this is related to the collection of bacteria at this interface between the abutment and the implant. A lot of times you see this in tissue that's thick. Thick tissue, the tissue or deep, would say the implant is very deep in, and that little bacteria, it's because it's an attached pontic, doesn't work its way out like you would have with a tooth with gingival auricular fluid, so it will come out the side. So you have to see exactly why this is occurring. Is it due to bacterial accumulation at that interface, or is it because these parts are not down or not attached? All right. Another thing that can happen that causes mobility is implant fracture. Now, I really haven't had this occur, probably only once or twice over the years in a fracture. I didn't take a picture. I didn't have one. I take a picture. Usually the bad things you don't take pictures of. But it's basically, you can have an implant fracture from metal fatigue. And some of the earlier implant designs used a pure titanium, which is a little softer. Now it's an alloy, so it doesn't fracture as much. But that constant pressure, say from like a bruxer on an implant, you would have it fracture. It's like a paper clip, which is the picture I did have, where you bend a paper clip back and forth, back and forth, back and forth, snap, metal fatigue. So this is a rare instance, but it can happen with implants that you have a screw or an implant itself fracture, which is even rarer. Another thing that can happen is that the bone to implant bond or osseointegration does not occur correctly, or was only to a modest degree, so the implant is loose. Now clearly on this film, the implant's really loose, but that's usually not the way. Usually it can be just a really thin amount of connective tissue or just tissue between the implant and the bone, because remember, it's supposed to be bone right up to implant. Then you'll see mobility, or the patient, when you press on it, will experience pain, and that's not good. There's only one way to really treat that, and that's remove the implant and put another one in. What we look for is inflammation. Inflammation can be due to plaque accumulation, or it could be because it's thick tissue, the pontic we talked about, or lack of attached tissue. So all these things can lead to inflammation around the tooth. Remember, some of these implants can be pretty buried. The more aesthetic they are in the maxillary anterior, actually, usually they're fairly deep apically into the tissue. You have a situation like this. It's very clear there's inflammation around the implants. This did lack attached gingiva. I didn't do implants but I did, on this patient, but I did see them to help build up tissue around the buccal of that implant or implants. You've got to remember with this is that implants don't have the capability to heal like teeth are. Implants are an attached pontic. They're titanium. They're not a living, breathing, substance in the body like teeth. So this is the difference between implants and teeth. Teeth can heal, have the potential to heal, where implants can't. You can get the tissue around it to heal, but the connection, everything is not changed. Okay, peri-implantitis, that is when the implant itself begins to get almost like periodontal disease around it. You'll see the bone go down, but usually it happens when the implant surface itself becomes contaminated with bacteria. With the new designs, you don't really see this as much. But in the older designs, like this that had a coating on it, the bone would just go down and you would watch the bone disappear. This one, like the picture I showed you before, this is very subtle, but this could be the beginning of peri-implantitis. And of course, has progressive bone loss that moves down, as we said. It's caused by bacterial infiltration, and you see it move down progressively. It's usually more severe than regular periodontal disease and can occur quicker than regular periodontal disease, so it's very important that we recognize it early. Patient that came in my office with implants like this, that is the surface of the implant itself. That's not the abutment that you see. You can probably see that the patient did not have bone on the implant surface itself. And I actually had to take this implant out, graft it again, and then re-put the implants in. So hopefully, in this case, we got it early enough, we were able to remove and replace it, and we used a different implant type that was less susceptible to periodontal disease. Okay, it's self-explanatory that they lack connective tissue resistance, diminished blood supply, it spreads rapidly. There are ways, or at least there's been attempts to try to repair this peri-implantitis. It was funny, back in the earlier days of implants, back in the 90s when I was in school, or the late 80s, there were certain areas of the country that were kind of the experts at trying to build the bone back on implants. And it used to be seen in the same places that were putting a lot of certain type of implants in. Implants that had certain coatings on them, like this HA or highly roughened surface all the way to the top of the implant, were more susceptible to this peri-implantitis. So they tried things like, this one's using a laser to decontaminate the surface of the implant. This is great, but it's really a delaying technique. If an implant has this much bone loss, it needs to be decontaminated, get it out, graft it, replace it. Don't watch as the person's maxilla slowly disappears around the implant. The damage is reversible, but very limited. That was the same implant here on the top. Here's the implant where it started out. They attempted a bone grafting procedure on it. Let me get it the other way. And see, here the bone particles are just floating around. It wasn't effective, and by the time we saw it, it was loose and had to be removed. In conclusion, and we're finishing up a little bit early. It's good. We got more time for the gifts, which is also the most important of the day. In conclusion, an implant is not a tooth. Don't treat it like one. It's an attached conic. All therapy should be designed around the fact that it's attached pontic. It's a biocompatible, relatively soft metal screw. All right, everybody, here's the big announcement for next year. You know what? I thought this was going to be a big announcement, but after hearing David Schwab this morning, I don't know if we could do much better than him. He was very good. We've had a very good run at speakers over the last couple of years. But one of my favorite speakers that we had, and a lot of people still come up and ask me about, is this topic, lean, mean, and dental hygiene, and David Mines. Remember David Mines, the nutritionist, everybody? He was very well received. So for the first time, we're announcing ahead of time who the speaker is going to be for next year.